So we've had seven fantastic talks, and conscious that I'd like to leave some time for questions. So first of all, we've got some questions that have been sent through the Slido app. But are there any questions from the floor? Yeah.
I just had a question early on about the percentage of heart failure patients in the region, and I just thought that number was extremely low when we just look at our own trust and caseload we see in town. Where do those numbers generate from? Is it new diagnoses per year, or is it you're looking at it from a big picture?
Those are the numbers. I'll just be Margaret. So those are the numbers that take directly from the text of the Cheshire and Merseyside heart failure pathway. I don't know how those numbers were derived. I'm assuming it's for heart failure audience, but I'm not sure. There will be a reference in the text that might give some more additional information on that.
It's a great point. I'll just come in on that because it depends a lot on coding. So the national prevalence is about 1%. Regionally, it's about 1.2, but there's still a lot of underdiagnosis and miscoding. So it's a great point. So I think those numbers are far lower than they actually should be.
There's a question that's come through on something I think is quite topical at the moment, SGLT2 inhibitors. So the question is, why are NICE not recommending SGLT2 inhibitors yet? I think that's in acute heart failure, Dennis, if you want to take that one. But then as a wider question, I wonder, Stuart, you talked about chronic heart failure management. Where and who do you think should be prescribing dapagliflozin or SGLT2 inhibitors in terms of primary versus secondary care?
So with regard to SGLT2 inhibitors, licensing was in December of last year, so we've had them for nearly 12 months in clinical practice. In terms of the NICE TA, NICE positioned SGLT2 inhibitors after beta blockers, either ACE or sacubitril valsartan, and spironolactone. I think that anybody who has symptomatic heart failure and either moderate or severe left ventricular dysfunction needs to be on all four key pillars of heart failure therapy. So all of those patients are eligible, and that's why the goalposts keep on changing in heart failure, and what was optimal therapy 12 months ago is no longer acceptable as being the best quality of care. In terms of the initiation of dapagliflozin, it's licensed to be prescribed, but it needs a specialist recommendation. So that recommendation can come from a heart failure MDT, and it can be initiated in primary care. Just a few things to highlight, and that's the difference in the prescribing indications for SGLT2 inhibitors for type 2 diabetes as compared to heart failure, because this causes no end of questions to cardiologists in secondary care. So for our patients with type 2 diabetes, there's a clear cutoff of GFR of 60 mils to initiate an SGLT2 inhibitor. And that's primarily based on the efficacy of SGLT2 in managing glycemia. In terms of its ability to manage heart failure, you can be much more liberal. And we have clear data down to an eGFR of 30 that SGLT2 inhibitors are good for the management of heart failure. So for dapagliflozin, which is the only one that's licensed in the UK at the moment, if you've got symptomatic heart failure, ejection fraction below 40%, and an eGFR of above 30, you're a candidate to be on dapagliflozin. In Europe, empagliflozin is licensed. It's got a license now in the UK, but it needs to go through NICE approval. So if you look at the European slides, it'll say dapagliflozin and empagliflozin, whereas most of the UK pathways at the moment simply have dapagliflozin. Just the only thing I can see really that's different is with empagliflozin, you can initiate with an eGFR of above 20 mils per minute. So even people with stage 4 chronic kidney disease should be considered for this class of medication.
Thanks, Stuart. We've got a question from Dr. Vijay Singh.
Thanks, Raju. Can you hear?
Yep.
It's from a primary care point of view. I just want to know, it's a sort of similar sort of question. What prevents interest of being commenced by the GPs to sort of maximize it before we hand over to the community heart failure team?
Thanks. Dennis, do you want to take that one?
Yeah. So I think, originates from the NICE guidance that says that it needs to be initiated by a heart failure specialist team. But of course, many heart failure specialist teams do include primary care. So I suppose depending on where you practice, it depends on your access to that heart failure MDT, I suppose. But I think as time goes on, I think there's definitely some GP practices, I think particularly in Bradford, where the GPs take on the ownership of starting, patients with Entresto. And if you think about it, in my view, it's no more complicated than an ACE or ARB. And half of it is an ARB. So these are, it's a treatment that clearly has been proven to work both symptomatically and prognostically. And I think it's just, I guess, increasing the confidence in primary care as they start to use it, because our experience is certainly very positive using it in mid-Cheshire. So I would encourage greater collaboration between primary and secondary care, so that we can shift some of these I guess prescribing practices away from secondary care, because in my view I don't think it needs to sit in secondary care.
Any other questions from the audience? If not, we'll go to some of the online, the virtual questions.
Yeah, there's a question here.
Hi, I'm Julie. I'm a GP and I'm appointed into primary care Cheshire CCG. Sarah's story was very telling. Are you able to comment on what you think are the main reasons why there are delayed diagnoses like this? This is apart from telephone consultations. We won't go into that. But.
Who wants to take that one?
I can.
Shabana, the early diagnosis.
So I think it reflects how non-specific those presenting symptoms are. And I think people's first instinct, particularly when they see a younger patient who is breathless, fatigued, isn't to think this is heart failure. And that's what we need to change. We need people to be thinking heart failure earlier on in that diagnostic pathway. But the fact is, most people will jump to, some sort of post-viral fatigue, I think Sarah mentioned, chest infections, just because that presentation is non-specific. So I think events like this are really important to try and raise awareness and educate our colleagues across primary and secondary care that actually you do need to consider this early as a differential diagnosis. But I think it's related to the non-specificity of the initial presentation, and also the high prevalence of comorbidities. And in an obese patient with COPD, for example, heart failure frequently comes quite far down people's list of potential diagnoses. And again, that just goes back to education and raising awareness that this should be considered early on, particularly because we can effectively rule in or rule out with the use of a simple blood test.
I think the other thing to say is there's a cohort of patients who we know have got heart failure, have maybe been discharged many years ago from the heart failure service after they've been optimised. Guidelines have changed, and they sit in the community and accept their symptoms. They think they're getting older, or they think they've got heart failure, and they're breathless, and they don't go and see their GP. So again, it's about maybe trying to find that lost cohort of patients, and there's going to be a talk later on about how we might do that as well.
Thanks, Matt. If there are no more questions here, we'll just go to the online questions. So one of them is asking about myocarditis and pericarditis, and what percentage can lead on to heart failure. Shall I give that to Ewan, maybe?
If you like, yeah.
Sorry, we're just sharing the questions.
How's COVID, please?
Yeah, with relevance to COVID, I think that's the hot burning topic.
Yeah, I think, well, it just depends, I suppose, and that's a vague get-out answer already, isn't it? So myocarditis and pericarditis are actually reasonably common. We pick it up at low levels all the time. But I think it's more the worry for me is when you then see them in that initial assessment is how's that affected the ventricular function. There's loads of guys out there that get a wee bit of myocarditis, or they get some pericarditis and a little bit of an effusion, and actually the ventricular function is very well maintained and they do really very well. And I think that what's then important is what then happens beyond that. So if you've got early bad ventricular function, that's clearly going to put you at very high risk. You need to be on them really, really early, really, really quickly, with all the prognostically beneficial medications you can think of to try and effectively reduce inflammation, which is the underpinning mechanism, let's not forget, of heart failure syndrome itself is actually an inflammatory condition. Now, those people who don't have much in the way of ventricular dysfunction probably actually do well. I tend to offer an echo for people about 3 months later if they've had a little bit of fluid or a bit of pericarditis, just to kind of touch base and make sure they don't fall through the cracks. I think if it's clear what the mechanism is and you've said, well, this is clearly a post-reactive thing, I don't worry too much, but it comes back to what's caused it in the first place. COVID's been a massive problem, hasn't it? We've tried to diagnose myocarditis in everybody, but I think we then have to say, well, if you don't know what the answer is and why they've got it, have you got an MRI scan? Have you looked at mechanism and cause? and actually got an up-to-date evaluation beyond medication of what the ventricular function is, because that's what's going to ultimately determine their ongoing risk, isn't it?
I guess the only other point is that it often presents as part of a multi-system inflammatory response, which may be vasculitis or some other conditions. So looking at autoimmune profiles, kidney function and so forth is vital. I can certainly think off the top of my head probably a handful of patients that have come through with non-specific chest pains, a bit of proteinuria, low-grade fever, and from my point of view, having gone through blood cultures and put them through a TOE and found they haven't got endocarditis, and them saying, well, you've got muscle aches, you've got joint pains, and maybe some skin rashes as well if you've now developed. You've got an underlying vasculitis and you require immunosuppression. And often the immunosuppression therapy is what kind of treats the underlying myocarditis. But just a word of caution that many of these people have relatively normal left ventricular function, but they can go through dips really quickly where the left ventricular function goes off completely. So if they phone you up and say, I'm breathless, you need to see them straight away. But often with good immunosuppression and heart failure therapy, their left ventricular function will fully recover.
Archie, I've got a question for you, actually. You put a slide up on the APAF trial, which was the looked at CRT versus medical therapy. So in that trial, I believe a large portion of patients had normal LV function. So are we now moving to a situation where patients should get an LV lead pre-AV node despite LV function?
So I think the trial needs to be taken with a pinch of salt. There was 133 patients in the trial. So sum total of 133 patients recruited over 4 or 5 years. Now, if you think about the AF patients you have in your population, your little cohort of heart failure patients, you have to ask what kind of patients were selected for the trial. Well, of course, my EP colleagues were very much, this is a game changer, you know, let's get a CRT and an AV node ablation. I think for the more pragmatic heart failure community, AV node ablation is an irreversible process where you're taking away the patient's own pacemaker. You're condemning them to being completely dependent on the pacemaker that you're putting in. So the bottom line is that, yes, these patients, although some of them had preserved ejection fractions, the mean ejection fraction was 43% in the APAF trial. So I think while there were a few patients with preserved ejection fractions, they all had to have an admission with decompensated heart failure. That was one of the inclusion criteria for the APAF. So you're not talking about a HFpEF patient class. They had to have persistent permanent atrial fibrillation, and they had to have had a decompensated heart failure hospitalization in the preceding 12 months. So that's the inclusion criteria. But going on to what was offered to them, it was a fairly aggressive trial. A CRT is not a no-risk procedure. It's a very safe procedure in good hands. Between 3 and 7% is what we would quote patients to have a 12-month risk, plus add to that another procedure, which is an AV node ablation. So these are, it's not to be sniffed at. This is not a BNP test. So I certainly wouldn't be offering it to all AF patients, but I think if you have troublesome AF patients, it's worth asking the question because there's emerging evidence. I think that's the way I would look at it.
Thanks, Archie.
There's one more question here, unless anyone else from the floor has got a question. No? So would direct access to echo improve diagnostic rates?
I think I'll take that because again that's a slightly burning regional and possibly national question. So historically echo was the main criterion which people would use to diagnose heart failure. Now with HFpEF, and again it's going to be 50-60% of the heart failure in the future, it requires careful interpretation. So there's so NT-proBNP, or no, it's a test with a very high sensitivity. So if it's a normal NT-proBNP, you can be 95% certain the patient does not have heart failure. If it's elevated, you can only be 50% certain. So it can be conditions like atrial fibrillation, CKD, simple aging, which can give you that. And then you add echo to the mix. You need interpretation to see if it is HFpEF or not. Because once you give a label of heart failure, it's for life. So it's putting that together with the clinical context, symptoms, blood test, and echo, which requires interpretation. And the other thing is there are conditions which have very subtle markers on echo. Amyloid is one classic example. So we don't want to be missing that out. The echo might so-called be normal LV systolic function, but they might have cardiac amyloid. So again, that's why we have said echo is only part of the diagnostic criteria. So we still go symptoms, BNP, refer, and echo is done as a one-stop service. Most heart failure diagnostic clinics offer a one-stop service where the patient gets the echo, gets the diagnosis conveyed and explained, do they have heart failure or not, and what further tests do they require. It might be an MRI, it will be treatments. So thanks.
Any other questions? I think it's time for, oh, we've got one more question before coffee time.
Sorry. All of your slides obviously indicate ACE inhibitor ARB prior to initiation of an ARNI. Your thoughts on prescribing in the community an ARNI straight away?
Yes, please.
I think going back to the pathway itself, it says ARNI or ACE or ARB. So we specifically mentioned that there. So it is the option of those. So ARNI can be initiated de novo, and I think one of the speakers emphasized on that as well. I think was it Stuart said that as well. It's I mean, especially with the pandemic, we've seen by the time we start an ACE inhibitor, optimize, then switch, the patient's either been hospitalized with heart failure or they don't have access to bloods, for example. So those are all the unique pressures the pandemic is exposed. But even otherwise, I think we are advocating an ARNI or ACE depending on the patient. If the patient's too frail, you're worried about blood pressure, then it may be ACE. But otherwise, ARNI first is what we say.
I agree. I think what's the point of starting 1.25 ramipril, taking 4 weeks to up-titrate that? I think you've got to make every contact count, establish these patients on the 4 pillars sooner rather than later. You know, there's a shift in the way we're looking at things now. We're gone are the days of start low, go slow. We need to get these patients optimised fast.
So I guess the challenge is, I don't think that's what Pan-Mersey is saying at the moment, is it? And, you know, as a community, we're restricted by the Pan-Mersey guidance. So I think it's all very well for us to say within this meeting, this is what we would do. But Pan-Mersey has to reflect that. And I think it's challenging to recommend people do it in one way when that's not supported by Pan-Mersey.
I think it's a very good point. Both NICE and Pan-Mersey, so they're lagging behind by a few years now, isn't it? So I think there will be something new. So so that's not to the detriment of Pan-Mersey, but with all guidelines, there is a little bit of a lag. Not all guidelines come out simultaneously in 2021 as they have, you know, with ESC and ACCHA. So I expect that is likely to change. But as a regional pathway, this is what we are advocating.
So can I just to clarify? Sorry, because this is the bane of my life that you see in young cardiomyopathy, you just want them on an ARNI.
Yeah.
Where do we stand as heart failure nurses? Because obviously we're led differently than being a medical person in our prescribing. If we chose to say, well, we're just going to put it in.
So I think that sort of patient, the ideal place to take that would be Rajiv's regional MDT, and then we've got a consensus to say.
Well, I'm not sure.
We
At the
can
risk of
start it.
sounding controversial, Matt, I think until Pan-Mersey actually okays it, because the last thing we want is to have conflicting messages with people starting off ARNI first, only for the patients not to have their prescriptions renewed out there. And I do think that is a big concern for me. And traditionally, I know with we know with our heart failure nurses that has been an issue in the past. And that is, I think nobody in this meeting is denying that the Big Four should be initiated. The principle of it is not in question. I think it's the logistics of it. And are we actually saying in this meeting as a body of expert and have we got consensus that we're okay with people starting ARNIs as a go-to de novo ARNIs and that somebody will continue the prescription?
So, I mean, my thoughts is that that's very reasonable, but I think you can't make that decision yourself in the community because so I think the great thing about Liverpool is that we have a big regional MDC where we can discuss those few patients. I think otherwise, yes, the Arch is absolutely right. We have to go with what Pan-Mersey and NICE are saying, which is you start off with an ACE inhibitor before Entresto.
I think the point we are making is, so we have ACE or ARNI, and it's a thought process, you are thinking. So like I said, there is a lag with a few guidelines, but we are encouraging that we at least think, and the patient might be suitable for ARNI first. But if you don't feel comfortable taking that decision on your own, involve an MDT, involve others. So it's a group decision. And that might be appropriate for a select few.
Now, the one thing to take out of the pathway here is that we're advocating that you can go straight onto an ARNI de novo. The European Society of Cardiology is absolutely clear. It's a 2B indication. You can do it. So we've got the guidance from Europe in terms of de novo initiation, and the pathway here is supporting it. There's going to be many groups of patients out there with very borderline kidney function and blood pressure where they're going to go through the standard historical therapies of starting on an ACE inhibitor. But these cases are great to bring to MDTs and to discuss. Obviously, they can only be initiated through secondary care. So the sooner you get the patient into that environment, the better.
In our practice, we initiate direct from nurse-led clinics. As a protocol, the patients get 3 prescriptions from us, and then after they have been optimised on their therapy, dependent upon blood pressure, renal function, symptom control, then the GP will then carry on prescribing it after 3. or more prescriptions, depending upon how many they need. It might take a little bit longer to get them to, say for example, hypotension, we'll start them on 24, 26. It may take us a while to get them up to 49, 51. But, you know, we will do our very best, you know, to be able to do that. But yeah, just was really your thoughts on.
Can I have a bash?
Do you want to?
I'll have a bash. That's what. Yeah, well, you might be. Yeah, I was going to say I'll have a bash because I think that's what it is, isn't it? I think I respect what everybody said today because in some way everybody's correct, and that's what when you're speaking to Dan and the rest of you. I completely empathise with these frustrations and the kind of appearance of flip-flop decision making because there is a bit of that. It feels sometimes, isn't there? What I would say when I said kind of fairly flippantly as well myself, yes, please. I think what I'd really like to push is the idea that my kind of personal aim, if I can achieve it, is 4 and 4. Try and get the 4 drugs in 4 weeks. That was kind of on the slide. It's a really good goal to try and aim for. Whether it's achievable or not is very, very difficult. We're all encountering some difficulties. We are a bit handcuffed by some of the logistics and the rules as it appears to be. So there is that. We have to observe that. And that's supposed to be based on what we think is safest for initiation for patients. What I've tried to do is be as flexible as possible and be as accessible as I can by email, phone, advice and guidance, because that's not to say, I think it's a slightly outdated view in that it's got to be a secondary care person that initiates it because clearly people in primary care don't know what they're doing. I think that's completely wrong in my view. I think there's the MDD that Rajiv's established as a reflection of that is to say should be a fairly more flat-based management approach to saying that we should all have an equal say in being able to make good decisions for patients. It's exactly what the transplant MDT does. It's all just the same for everybody. So what I would like to think is that if we can make each other more accessible for discussion, it ticks the pan-MERSI box by saying, yes, we have initiated, because I used to get phone calls from Dan all the time and just be like, you know, I think this, I think that. I'd have a look at it, we'd have a chat and go, yeah, I think this is a good idea. I took it on the head and said, well, yeah, it's my responsibility, it's my initiation, but I wasn't actually doing all the work. Dan was doing all the work, do you know what I mean? So I think that has to be acknowledged, that there's people out there doing all this work, feeling handcuffed by rules, and we need to try and promote safe initiation and safe optimization of medication, but try and remove some of the barriers that are maybe a little bit outdated. But I also agree with Shabana and Archie completely that we don't want to be the people that say, yeah, you go and do it, and then pan-MERSI come back and, you know, shoot you in the face, and then you're left, you know, clearing up the mess by yourself, because it's not a very nice place to be, is it? So I would say that I think we all empathise entirely with the position that you've outlined there.
Thanks. So I think these are discussions which will carry on throughout the day. So the objective, one of the objectives of this meeting is to sort of, oh, sorry, we've got one more question.
Is there anybody here from pan-MERSI today?
Ooh,
no.
Sorry, Christine?
Is there anybody here from pan-MERSI today?
I think we're all from pan-MERSI.
The actual medicine.
As a body and a region.
The people who have the decision-making ability to sort of change the schedule, because we've had consultations with yourself, Rajiv, where patients have been recommended to go on dapagliflozin, and your pharmacists out there are saying because of the pan-MERSI guidance, they're not doing it, even though they can see your review on EMIS and they can see it's consultant-led, they're still refusing to initiate it.
Thanks, Christine. Sorry, it was a bit of an I'm Spartacus moment. But yeah, in terms of dapagliflozin in particular, the pan-MERSI guidance has changed to what is what has been advocated by NICE. So that's imminent, I'm told. So that should change things. And with DAPA, especially GPs have prescribed this for SGLT2 inhibitors for 8 years. They have a lot more experience than some of us so-called heart failure specialists. So I think it was a bit restrictive, but yeah, there is consensus now and it has changed. Sorry, Matt.
Hi, Rajiv. It's just an observation, really. I think the discussions is really useful here for someone to take back to pan-MERSI, but what you need to remember as well is you need to involve your local medical committees as well. You know, even though pan-MERSI might agree and sign it off, some GP practices will not still initiate it. So making sure you have a consistent approach and engaging with both pan-MERSI and local LMCs is really important.
Thanks. Thanks so much.